Well, you've made it this far. This is the last of 5 parts in this series on clinical anatomy of the thorax. This last presentation isn't really so much a presentation as it is a quiz that you can take to help reinforce the knowledge that you should have gained over the previous 4 presentations. If your school uses the clinical presentation curriculum, you might want to listen to the review of these schemes. You might be able to glean a little bit more information about how this clinical anatomy of the thorax is relevant to the plethora of presentations that a patient may present with to your office. Whether you're a physician assistant, a physician, a surgeon, or a dentist, you're going to see patients who present with hoarseness, a cough, lymphadenopathy, perhaps chest pain or shortness of breath. All the information in this presentation on clinical anatomy of the thorax will help you come to the right decision whether to treat or refer your patient. Congratulations on completing all 5 chapters of this presentation. If you have any questions, please feel free to email me. The following slides review clinical conditions for which knowledge of the anatomy of the thorax and of the mediastinum is important and relevant. Many schools participate in the clinical curriculum presentation, where each presentation, i.e. cough, shortness of breath, fever, headache, abdominal pain, etc., are used to teach how a topic is actually presented to the students. If your school does not participate in the clinical presentation curriculum, you don't really need to review the following slides. But if you'd like a more complete knowledge and collection of those presentations that your patient could present with that are related to the anatomy of the thorax, keep listening. I hope you've enjoyed these presentations, and if you have any questions, please feel free to email me, and constructive criticism is always welcome. Thank you. The most obvious is an abnormal chest x-ray. If a patient presents with an abnormal chest x-ray, anything in the mediastinal or thoracic cavity could be the cause. Take a minute to look at the variety of causes of an abnormal chest x-ray, including not only fractures, pleural effusions, pneumonia, atelectasis, but even mediastinal diseases, such as cancer in the anterior, middle, or posterior mediastinum. It's all relevant. It's difficult to completely understand the pathophysiology of altered Starling forces unless you understand the interplay between the mediastinum and the thoracic cavity. Heart failure, right ventricular failure, constrictive pericarditis, and a pericardial effusion are all pathological conditions related to the mediastinum, to the heart, and to the pericardial sac. Altered Starling forces can occur because of increased capillary permeability, decreased capillary oncotic pressure, or increased capillary hydraulic pressure. It's all related, and you'll need to understand the anatomy of the thoracic cavity and the mediastinal cavities in order to understand the altered Starling forces that can occur. Of course, it inherently makes sense that in order to understand chest discomfort, you need to understand the anatomy of the heart and the pericardium. But what about the non-cardiac causes of chest discomfort, such as a pleural effusion, pneumonia, atelectasis, broken ribs, cancer? In order to complete this scheme, you'll definitely need to understand the anatomy of the thoracic cavity and the mediastinum. Let's not forget other causes of non-cardiac chest discomfort, such as gastrointestinal complaints, which will be covered in your GI course, musculoskeletal diseases, which can cause chest pain, such as arthritis, and of course, psychological causes of chest pain. But in order to rule out any of the other diseases which can kill the patient, you have to know the anatomy, the physiology, and the pathophysiology before you tell the patient that they're nuts and the pain is in their head. It seems that the list is going on and on. We've talked about pneumonia, and we've spoken about bronchitis and tracheobronchitis, a collapsed lung, also known as a pneumothorax. But what about pulmonary hypertension, or a pulmonary embolism, which can cause chest pain? As you can see, chest discomfort, cardiac and non-cardiac, is innately related to all of the anatomy which we're going to learn. But it doesn't end in your cardiopulmonary course. It continues in your neuromuscular courses, your gastrointestinal courses, and even your psychology courses. In this scheme, it's specific and mentions pancreatic disease. Pancreatitis is well known to cause a left-sided pleural effusion, which can lead to left upper quadrant pain and shortness of breath and respiratory compromise. Chest pain, whether it's cardiac or non-cardiac, is innately related to the anatomy of the mediastinum and to the pleural cavities. It goes without saying that throughout your career you're going to be treating many patients who present with a cough. But that cough could be from congestive heart failure, it could be from medications, it could be from a psychological condition, or of course it could be from pneumonia or cancer or even reflux disease. The list goes on and on. The point is, it's not just limited to the anatomy that you'll learn in your cardiopulmonary course. It's related to everything that you'll see as a physician. Therefore, many of these schemes, which are usually talked about and limited to your cardiopulmonary 1 and cardiopulmonary 2 courses, will extend into your gastrointestinal course, also your musculoskeletal course. What about the patient who presents and they're blue, they're cyanotic? Is it because they have a disease of their central venous system or their peripheral venous system? Could it be that they're hypoventilating or they're in respiratory distress or they're born with a congenital anomaly? You have to understand the anatomy of the pleural spaces, the lungs, the thorax, and the embryology of the heart and how it develops in order to completely assess a patient who presents with cyanosis. In this scheme, we note that a cyanotic newborn is assessed to either have an airway obstruction or non-obstructive causes, such as a cardiac anomaly, tetralogy of Fallot, or even a weird anomaly causing dysphagia, such as dysphagia lusoria, where they have difficulty swallowing because of an aberrant aortic arch. What if they have a foreign body in their right mainstem bronchus, or they suffer from reflux disease? This is from the GI course. This is from an embryology course, and you can also have neurological causes of cyanosis. How can dizziness be related to anatomy of the heart and to the mediastinum or the thoracic cavity? If the patient has a cardiac arrhythmia, they can become dizzy. Or if they've had a heart attack, they can become dizzy. Or if they have pneumonia or sepsis, this can also cause dizziness. It's all related. As a surgeon, I saw many patients who presented with chest trauma. Most of them lived. It was important for me to assess them from a trauma point of view to make sure that I could either save them or I could treat their pneumothorax or their fractured ribs or their flail chest or their ruptured abdominal aortic aneurysm or their expanding thoracic aneurysm or simply treat their hemopneumothorax. Dysphagia is difficulty swallowing, and this scheme will be introduced in the GI course. However, there are cardiac causes of dysphagia. One I just mentioned, dysphagia lusoria, which is a congenital anomaly. What about very prominent or expanding aortic arch, which can cause dysphagia, such as an aortic arch aneurysm? What if the esophagus has a stricture? The esophagus is in the mediastinum. It's in the posterior mediastinum. Again, if you don't understand the anatomy and the relationship of the esophagus to the trachea and the esophagus and the trachea to the aortic arch, you won't understand the physiology which you're learning. Dyspnea seems like a no-brainer. Patient presents with shortness of breath, and it's up to you to find out why. They could be short of breath because they've had a heart attack, or they're having angina, or perhaps they have pneumonia, or a pneumothorax, or they've had trauma, or perhaps it's not any of the above and they are simply anxious. You'll see it in your GI course, your cardiopulmonary course. You'll also see it in your psychology courses. Of all of the things that can cause a fever, one of the most common that you'll see is upper respiratory tract infections and lower respiratory tract infections. Pericarditis can present with a fever, as can pneumonia, an infected pleural effusion, even pancreatitis. And believe it or not, sometimes trauma or cancer can cause the patient to have a fever. The parathyroid glands are 4 small glands located on either side of the thyroid. Now the thyroid rests outside of the mediastinal cavity, but parathyroid glands can rest in the thymus, and the thymus is located in the anterior mediastinum. Another cause of hypercalcemia is broken bones or broken ribs or trauma. So if your patient presents with hypercalcemia and they have a malignancy or broken bones or even hyperparathyroidism, it could be related to the anatomy in the mediastinum and the thoracic cavities. Cancer, broken bones, ectopic parathyroid glands, it's all there and something you need to think about. Can you think of some common causes for hypertension that are related to disease processes within the mediastinum or the lungs? What about coarctation of the aorta? Can't that cause hypertension on your physical exam with high blood pressure in one arm but a normal blood pressure in another arm? Can it cause systemic hypertension? What about congestive heart failure? Can it cause hypertension? What about cancers and malignancies? Have you ever heard of carcinoid syndrome? Can it cause hypertension if it metastasizes to the lungs? Why do I need to know the anatomy of the lungs in order to diagnose somebody with hyponatremia? Because there is a certain lung cancer, usually oat cell carcinoma, also known as small cell carcinoma of the lung, which can present with a low serum sodium. You need to be able to understand the anatomy of the thorax and the lungs and the mediastinum if your patient presents with a lung cancer. You'll need to know how to work that patient up, to refer them, to assess whether they have metastatic disease in the mediastinum, and to refer them for possible lymph node biopsy or even biopsy of the lung mass. And if a biopsy does occur, what happens to a pneumothorax if they get a collapsed lung from the lung biopsy? All related and not necessarily just limited to the cardiopulmonary course. What about a very low blood pressure, hypotension, or even shock? Well, we can think of septic shock or toxic shock, but what about a patient who presents and they had a stab wound to the chest, and now they present hypotensive because they have a tension pneumothorax, or they've bled into the chest so much that now they present with cardiogenic shock from lack of blood. All of it's related, and in order for you as the physician to treat them or refer them, you'll need to understand the causes of hypovolemic shock, cardiogenic shock, pulmonary shock, septic shock, and even medications which can cause hypotension. And if they cause enough hypotension, can they cause a heart attack? And in order to understand that, you need to understand the anatomy of the heart. One of the biggest causes of mortality in the United States is still lung cancer of both men and women. A patient presents with hilar and mediastinal lymphadenopathy, may have a lung cancer, and you'll need to understand how to diagnose it. It could be lymphoma. Should they have a lymph node biopsy? Should they undergo a Chamberlain procedure or a mediastinoscopy? Can you simply biopsy the mass in the neck? Is that the right thing to do, or should you do a fine needle aspiration? Some of the answers to these questions you will learn in your GI course and on your head and neck, ear, nose, and throat rotations. But some of it is applicable throughout your medical career and as part of your cardiopulmonary course. Malignancies of the hilum of the lung and the mediastinum, and depending on what compartment of the mediastinum the malignancy is, will help determine what the diagnosis is and treatment for that patient. What if that patient presents to your office and feels an abnormal lymph node in their armpit, but on your workup you find out that they have multiple lymph nodes which are abnormal, greater than 1 centimeter in size, in the hilum and the mediastinum? What will your diagnoses be? How will you work this patient up? Can you treat them in your office? Can you perform the biopsy in your office? Should you treat them? Should you perform the biopsy? And what happens if you find that they have hypercalcemia? Could it be a malignancy? Could it be hyperparathyroidism? Could it be a metastatic breast cancer? These are all decisions that once you understand the anatomy of the thoracic cavity and the mediastinum, you'll be able to understand and assess much better. You got to be kidding, right? A neck mass? That's not in the chest. I already mentioned to you about hyperparathyroidism and the fact that there are usually 4 parathyroid glands, but there can be as many as 8 to 12 parathyroid glands, and they can be found in the thyroid gland or even the thymus in the anterior mediastinum. What if a patient presents to you with difficulty swallowing and they have what's called a goiter? And what if that enlarged thyroid gland extends below the sternum into the anterior mediastinum? That's called a substernal goiter. You need to understand the anatomy of the thyroid and the anatomy of the aortic arch and the trachea and the aortopulmonary window before you refer this patient to a surgeon. Congenital causes of neck masses also need to be understood, whether they're cystic or non-cystic, whether they're infections or cancers, or their metastatic disease. It's all related. It's a big space with lots of important structures. What if a patient presents to your office with a nipple discharge and it's a man? Could it be a breast cancer? What if it's a female? Is it a breast cancer? You need to understand the anatomy of the chest wall, as well as the potential that a nipple discharge is from a cancer of the pituitary called a prolactinoma, and the treatment is bromocriptine. To understand the anatomy of the breast and the chest wall extends to knowledge of anatomy of the central nervous system. You're kidding, right? Numbness and tingling? What if the patient is simply anxious and they are hyperventilating? Isn't that related to physiology of the lungs and pleura? What if the numbness and tingling is from a tumor pressing on the nerves of the brachial plexus high in the neck and near the axilla? What if it's a tumor of the central nervous system, such as a spinal cord lesion or a lesion of a nerve root plexus, causing hyporeflexia or areflexia? It's all related. Sometimes a patient can actually present with claudication of the lower extremity, and they present with causalgia. Causalgia used to be treated by dividing a sympathetic chain ganglia via a thoracotomy, an operation related to history, but they used to do it and they had to know the anatomy of the thorax. Any of the pain that we've spoken about already could be related to any of these causes. Psychological chest pain, a tumor in the posterior mediastinum, such as a schwannoma. We already mentioned dizziness and the fact that heart palpitations can cause chest pain, and the fact that perhaps the palpitations are from valvular disease or cardiomyopathy or even cardiac tumors. All of it's related, and you need to know the anatomy of not only the heart but the mediastinum to assess and to treat your patient. What if the patient presents and they've been poisoned and now they're in respiratory distress? Or perhaps they've taken a drug overdose and they have severe respiratory depressions. It's important to understand the physiology, the pathophysiology, and the treatment for this patient. And in order to set up the patient's ventilator, you're going to need to know their weight, their tidal volume, and understand the physiology behind the anatomy in the chest, the pleura, and the mediastinum. We see, if we look at nodes G and H, that the pulmonary and cardiac systems can contribute to the development of polycythemia, which is an artificially elevated hematocrit, which means simply you have too much red blood cells, which can cause hyperviscosity and lead to strokes and embolism. Perhaps the patient even suffers from severe pulmonary disease resulting in hypoxemia. The body, in an attempt to increase oxygen delivery, makes more red blood cells, leading to polycythemia. What about recurrent infections or persistent infections that have been treated again and again and again? One of these is empyema and pneumonia. If a patient develops an infection in lung tissue distal to a bronchus, which is obstructed by a cancer, this will result in a persistent pneumonia and atelectasis of that lobe of the lung. This in turn can cause a lung abscess. Of course, you can induce an infection in the pleura by infecting it iatrogenically. A thoracentesis, a chest tube. These are therapy-related infections. Disease-related infections such as pneumonia, empyema, sarcoidosis, etc. can all lead to infections. Pulmonary disease can lead to metabolic abnormalities such as a respiratory acidosis or a respiratory alkalosis, and these metabolic abnormalities can in turn lead to seizures if they're severe enough. What about a tumor of the posterior mediastinum, which is pushing on the sympathetic ganglia, or perhaps even eroding into the spinal cord? You have to know all of the anatomy of the mediastinum and the thoracic cavity to better understand spinal pain as a result of thoracic pathology. This one's a no-brainer. Any disease process caused by trauma, such as somebody getting stabbed in the chest or perhaps hitting their sternum on the steering wheel during a head-on motor vehicle collision, can result in all kinds of pathologies to the chest, mediastinum, and thorax. Of course, sporting accidents or assaults or just simple accidents at home can all lead to traumatic injuries of the mediastinum, the pleura, and the thorax. Here we're looking at white cell abnormalities. A patient presents to you with a high white blood cell count, which can be indicative of infection. But what about broken ribs? Broken bones in general can increase a white count, or cancers, or infection, which you're more than aware of. Here's the references for this presentation. We have gone through the relevant schemes, a review of the anatomy of the pleura and thoracic cavity, pneumothorax, central lines, video-assisted thoracic surgery, pleural effusions. We've just given you a ton of information. I've attached all of these PDF files to this Adobe Presenter so that if you want to read more, you can. And just in case you get confused about finding those PDF attachments, only on part 1 will you find those PDFs, and they're attached under a paperclip icon where you can download them directly to your desktop. That's it. You've completed all 5 sections of clinical anatomy of the thorax. Please remember that materials presented in this presentation are often the property of the respective copyright holders. In this case, many of the images belong to the publishers of the TEMA Atlas, Lippincott, who publishes the Rowan's Atlas, and Toltec, who publishes the VH Dissector. Copyrighted materials can be used for educational purposes, and only 1 copy per student is permitted for educational purposes, and redistribution is not permitted.